Good afternoon, everybody. Thank you for the chairman for the introduction. We have we have just heard a very interesting talk of Professor Umapati. Helped me very much in my presentation because we have very interesting and precious information about the clinical uh, approach for the patient. So my talk today is about the application of vestibular compensation for the treatment of vertigo. So first of all, I will uh, remind you a little bit about the approach to diagnosis. I think it is a similar approach like Dr. Umapati had talked, but it's another way to talk about that. First of all, we all know that our balance system is having the contribution of three main system to provide the information. That is the vestibular system, the vision, and the proprioception system. On three system give the information for the brain to integrate and to make our keep our balance. And if one of these system has an abnormality, we will have a problem with balancing, and we can have the symptoms of imbalance or dizziness or both. Uh, Here is the main etiology of the dizziness. We can see here we have around half of them is have a vestibular origin, either peripheral or central. And all of us, you are afraid of the central cause of the dizziness. And we also have the syncope cause, and also the neuropsychology cause of the dizziness. So how we can make a diagnosis with that? It's another way to talk about the approach. Uh, you all know that the characteristics of the dizziness is very important to distinguish between the vestibular or non-vestibular symptom. But in reality, in practice, we can see that many patients cannot tell more clearly about that symptom. They cannot confirm that they see the rotatory the motion, illusion, or any other sensation. We will assess about that, but we not totally rely on that to make a diagnosis. So we can use the mnemonic titrate to do the approach for the patient. First of all is the timing. We can classify the syndrome into acute, episodic, or chronic. And then we assess for the trigger. Is there a trigger like positional, visual, or spontaneous, or anything else? Then we assess for all the associated symptoms, and especially the targeted examination, including some tests. So for the timing, for the acute syndrome, we have we had the common suggested etiology is about the vestibular neuritis or stroke, or even stroke induced. We classify into this type of acute when there is an acute onset and it's the continuous. It lasting for days to weeks. And if we have another syndrome of episodic, that means it happened as like episode, lasting for several seconds to minutes. And we had another thing is chronic duration, maybe lasting for several months or years. So for each syndrome, we had some specific etiology, and to do the diagnosis, we move to the another feature is that the trigger and do the exam. For the for the trigger and the exam, we can see that for the acute syndrome, if it happens spontaneously, we had the two main causes, the stroke and vestibulitis. And we can use some tests, especially the hint test, like Dr. Professor Matati had told us. And we try to look for any focal deficit. We also have some medication that can cause acute dizziness like this, and we had to ask for this in the history taking period. For the episodic, we have the well-known PBPV. It is the episodic, very short, lasting episodes of dizziness or vertigo, and it's triggered by positional trance. And we can do other tests to differentiate between the cause. For example, this Pi test is for the BPPV. For the chronic one is the anxiety, and now we have the new term of PPPD is in persistent positional perception disease, and it's related to anxiety and stress, something like that. So we can come to some cases to see how can it do that using the titrate acronym. So this is the first case of Merle, Male with no medical histories of hypertension, and the histories of sudden spinning dizziness. And when vertigo is exaggerating on opening the eye, it's happen continuously. It just mildly decreases when closing the eye, and accompanied with nausea, vomiting, and my headache. No abnormality in the speaking, swallowing, or no weakness. So for the timing, it's acute, isn't it? And it's no trigger. So the possible etiology is stroke and vestibulitis. Then we do the examination, which show that there's a rotatory nasal at rest, left arm ataxia. So we can suggest that is the possible acute vertigo with ataxia, and possibly the posterior stroke. And we do the MRI. The MRI show that there is a infarction of the cerebellum on the both side, but predominantly on the left side. So the patient was treated using the stroke protocol, plus some antibiotic as needed. The second case, we can see here a female, 60 years old, no notable medical history, and what suddenly happened of vertigo on awakening when he's sitting up, and with nausea and vomiting. It lasted just about 30 seconds. Recur when lying down or turning to left, but not happen when the patient is on supine or turning to the left. So the timing is acute, but it's a episodic vertigo, and the trigger is positional. So the possible etiology BPPV, or even sometimes we had a central positional vertigo. We do the neurological examination and the test. We show that no deficit, no nystagmus, and only this Pi maneuver is positive on the right. So the diagnosis now is BPPV, and the treatment is apply maneuver with some medication and rehabilitation for particular function as needed. The third case is a female of 45 years old, admission with vertigo. The patient showed that there is a sudden spinning vertigo continuously from 12 hours before the admission until the admission, and still accelerate on turning the head, no hearing loss or tinnitus. And the timing now is the acute dizziness, and the trigger, we had no trigger. So the possibility is still stroke and vestibular neuritis. Can we do the MRI now? No, we do the examination first. The neuro exam show horizontal nystagmus and accelerate a little bit on turning the head, and the hint test said no central cue. So we decided that the diagnosis would be vestibular neuritis, and treated with some medication, vestibular rehabilitation for the patient. So that's just some case in the process of this. And for the vestibular problem, some patient who complains very anxiety and very fear of the sense of vertigo. But we should tell them that it's normally it's a very benign case. But why it's benign? Because there is a vestibular compensation. The vestibular had the ability to compensate for its reason. We have seen this before in this is the vestibular system. So it's used the semicanal and also to give the information about the motion of rotatory or even the straight motion or the head position. Normally, the two vestibular organ in the both side will give the actively dynamic balance in the signal come to the brain. It's dynamic because it depends on the position and the movement of the head, and is appropriately send the signal to the brain, so we can sense our motion and there's no vertigo there. But if there is a damage of one side, there's an imbalance between the signal between two, and our brain will sense that it's the rotated even if the head is not moved. So that is the illusion of motion. It's a real vertigo of the vestibular system. We can see here a little bit more detail about the, what happened when the patient is at rest, and when turning the head is a normal thing. We had an imbalance between two, but it's appropriate with the motion of the head, so it's normal sensation. But when there is a damage of one side, there's an imbalance even if the patient doesn't move the head. So the sense now see the vertigo, rotation vertigo. And our vestibular system had the capacity of compensation. The compensation comprised of restoration, adaptation, or habituation. For the restoration, that means the lesion, it can return by themselves to the normal state. Is very realistic, very ideal for the compensation. For example, the BPPV or even the vestibulitis, it can heal by themselves and then it's returned to normal. But before that, maybe it's still have the symptom. So for this situation and others, we had other compensation action like adaptation and habituation. It can have the static compensation and dynamic compensation. The dynamic compensation is comprised of the changes of the whole brain to adapt for the damage. Here we can see that in the first phase, maybe there is a intervention of the nervous system to reduce the signal of the normal side, to reduce the imbalance between the two signal of the two one, and then it's a little bit enhance the action of the nuclei of the impaired side. It's the complete compensation is the static and the dynamic compensation. And here we can see here the overall view of the compensation process. So what I want to talk here is that if we have a very good compensation, we will reach this situation. I mean that there is a very well balance between the two sides. But when we have something to inhibit the vestibular system, we will still have the compensation, but in a very low level. So at this time, we can have the at this time we can have the reduce the symptoms of vertigo, but the balance is poor, so the patient is easy to form. So in application for the treatment, what should we do? first of all, we should limit use vestibular sedative or inhibitor because it can reduce the capacity of compensation. We can reduce the symptom of vertigo, but the patient may have poor balance, and also the compensation will take longer and not complete. So we should not use or just use for short term. It is the list of some agents that can have the vestibular inhibition. We should not use for a long time. So we just use if for acute, very severe acute peripheral vertigo, we just use for a very short time, 1 or 2, 3 days. Sometimes we use for central vertigo with vomiting. But we have some other agent that not suppress the vestibular system, but it's supportive of facility. It helps the facilitate the vascular compensation like this. So we should use this thing for a longer time. Some agent we can have availability. That's the beta histine, acetylcysteine, and other thing. We had some evidence of some of these things, but it's not so much. For example, this is a small study of 29 patients. We can see the effect of beta histine. Apart from the medication, we should use the treatment appropriate for the etiology. For example, we use airplane maneuver for BPPV is a very good treatment for etiology of the patient. Sometimes we can use Van der Rohe exercise for the patient to use at home. For some of the selected patient can use this to recover the function. And we should implement vestibular rehabilitation when needed, especially for some of the disease that cause damage, longer damage to the vestibular system. For example, the vestibulitis. We should use gait stabilization exercise, habituation exercise, or standing balance activity, walking or fitness endurance when tolerated. It depends on the situation of the patient, and it's what delivered by the physiotherapist. So for the take-home message, I can suggest the titrate approach to dizziness is very useful, and for clinical practice, we should pay attention to the compensation in order to use appropriate medication and rehabilitation when dealing with the patient with vestibular disorder. Thank you very much for